Hello everyone, I'm Dr. Roopali Khanna. I'm additional professor in Department of Cardiology in SGPGIMS, Lucknow. So my today talk would be related to your ambulatory blood pressure monitoring, and basically what is the relevance in clinical practice, how frequently and how effective this modality is in diagnosing the patients who are hypertensive, and what added benefit we have when we go for this modality. A little brief history of what if we see the blood pressure. The first blood pressure measurement was in 1896 by Rocky. So if you see that is now more than a century and we are talking about blood pressure, because this simple modality or this simple measurement of a risk factor or a disease has led to treatment and leading to a better outcomes. In past 1 century, if you see, there have been not much changes in the measurement of blood pressure. Still, we are going for your routine measurements in the patients who are coming to OPDs and they have to be evaluated. And if we want to emphasize, the blood pressure is the most important vital sign which has to be evaluated in each patient may above 40 years of age. At least once he should be get measured for this blood pressure. Why so much importance is being given to blood pressure or hypertension? It's because the hypertension per se is attributable to your various diseases. So if you see, if just patient is hypertensive, there are various other risks or whether diseases can develop in this patient, starting from your heart failure. It can lead to stroke, cerebral hemorrhage, chronic kidney failure, hypertensive encephalopathy, retinopathy, peripheral vascular diseases, aortic aneurysms, left ventricular hypertrophy, myocardial infarctions, and coronary artery disease. So by just controlling this hypertension, we can control all these different diseases which can be a byproduct of hypertension. Per se, if you ask, blood pressure or hypertension doesn't cause any symptoms, but when it becomes uncontrolled or when it causes target organ damage, then it is a catastrophe. By this target organ damage, then the modalities of treatment and the risk factors and the outcome of the patient is very much affected. So if we can just control this blood pressure, we can save the patient from various diseases. So before starting my talk, I will give you 4 case scenarios. We will discuss regarding 4 case scenarios, and then we will see how this modality of ambulatory blood pressure monitoring is helpful in these different case scenarios. So the first case is basically a patient, a 40-year-old female. So you're sitting in your OPD and she is a 40-year-old female, comes to your OPD, she is non-diabetic, and she says she has 2 readings of blood pressure of 150 by 80 mmHg. You record it, you make her sit for another 5 minutes, again take the reading, it's again 150 by 80 mmHg. She denies any family history of hypertension. There is no evidence of target organ damage. Now what to do next? Should you advise antihypertensive to this patient directly? Or you should say, okay, let me do some more investigation and see what else is there. Is it a white coat hypertension or whatever the reason it is? Let me evaluate it again. A case scenario 2. Now this is a 55-year-old male. He is obese, he is mild renal dysfunction, and he is already on 2 drug therapy. His blood pressure in your office recordings is always showing 130 by 80, but despite that office BP recording of well-controlled blood pressure, he's still having a progressive renal dysfunction and left ventricular hypertrophy. So what to do next? You would assume that this left ventricular hypertrophy or renal dysfunction is per se your patient is underlying chronic kidney disease, or there is something else which we are missing in this case. If you will see a third case, now he is a 30-year-old male with a male smoker, and he has a reading of a BP of 130 by 80, and he presented with your mild renal dysfunction and concentric LVH. So what do we assume? He is not a very big athlete and he's having a good sedentary lifestyle. So what to do next? Should we label it, okay, he's hypertensive, or should we say, okay, that we have to see whether it is normotensive, or we have to investigate if it's hypertensive or not. And a fourth scenario is a 65-year-old female. He's in atrial fibrillation on 3 drug therapy, and continuously her BP recordings are 180 by 100. So should we go for a ambulatory BP testing in these cases, or should we just keep it on medical follow-up? So coming over to all these scenarios which I discussed, first we have to see the criteria or what are the different methodology by which we can diagnose hypertension. So if you see this, there are various guidelines which have been proposed, and recently there have been major changes also in these guidelines. Recent guidelines, which was in 2017, ACC proposed the guidelines for diagnosis, prevention and detection and evaluation of the patients with high blood pressure in adults. In 2018, ESC came up with the guidelines for management of hypertension, and recently in 2019, NICE presented the guidelines for hypertension in adults diagnosis and management. So if we look at about these guidelines, now their criteria for the cutoff, there has been some changes. ACC now say to diagnose on hypertension, it says take a cutoff of 130 by 80 mmHg. So it labels a normal blood pressure to be less than 120 by 80, elevated or a high normal to be 120 by 30 and less than 80, whereas it's labeled stage 1 hypertension is as more than 130 by 80. But if you see the treatment stuff, it doesn't say that treatment should be started in all the patients who present with 130 by 80 mmHg of blood pressure. They say look at the cardiovascular risk scores, evaluate them, and then we see whether the drug has to be started or not, or you just have to advise lifestyle modification in these cases. If we see your ESC guidelines, so ESC guidelines, they cut off, they have kept it as 140 by 90. They say it's okay. Office blood pressure, if it is more than 140 by 90, we will diagnose it as hypertensive. Otherwise, we will just try to keep it on, not label it as hypertension, we will label it as a high normal blood pressure. But they added two more things. They said, okay, we have to evaluate for this patients for ambulatory blood pressure monitoring also. What is it? If it is ambulatory BP monitoring, if the 24-hour BP is more than 130 by 80, then also they label it as your hypertensive. So if we compare these two guidelines, the blood pressure, clinic blood pressure, if they say, the ACC say it should be more than 130 by 80 to diagnosis for hypertensive, whereas ESC says 140 by 90 mmHg. Whereas if we see the home BP monitoring, it says 130 by 80 and ESC says no, 135 by 85. And if we go for your daytime BP and the nighttime BP, again there is a difference of 5 millimeter of mercury. So in net, it is if the ambulatory BP is on the higher side by 130 by 80, then you have to label these patients as hypertensive. But why do we need this out of office BP monitoring? Why can't we say, okay, that's the clinical BP monitoring we will do and that would be more than enough? The data have shown that the clinical office BP monitoring is always not very accurate, and they have not shown a very good correlation with your cardiovascular mortalities and morbidities in future as compared to the out of office BP monitoring. So there are two modalities by which we can do a out of office BP. One is your ambulatory BP and the second one is your home BP monitoring. Ambulatory, I will just discuss what it is, ambulatory BP monitoring. So basically ambulatory BP monitoring is a device which is usually worn by the patient. The cuff is tied, most probably a non-dominant arm or whatever the arm with which they have a higher blood pressure. And the patient the device is connected, which is a small device about like a size of a mobile, and it is given inside the pocket of the patient. Now this device takes blood pressure to a period of from 24 to 48 hours depending on the battery life, and the parameters which we can set in these cuff inflation is during daytime we can set at the frequency of 15 to 30 minutes during daytime, and during night we can set the frequency from 30 to 60 minutes during night. Then according to it, average daytime and average nighttime BP is calculated and a 24 average BP is calculated. Now how to define that nighttime? All the machines are usually programmed nighttime from 10 p.m. to 6 a.m. But this programming can also be changed by depending on the patient's waking and sleeping hours. It can be from 11 a.m. to 7 a.m. or it can be your 9 p.m. to 6 p.m. Why this nighttime timing is important? Because I will show that why the night BP monitoring and the daytime BP monitoring should be assessed separately. So there are certain instructions which are given to the patient whenever the ambulatory BP monitor is tied up. First and foremost, there should be not any thick covering in your arm. A patient should wear a short sleeve shirt or a blouse or very thin cloth so that the cuff can be tied across it very easily. Second, the patient should be counseled. See, if it is very, we all have got your blood pressure got measured, the inflation of cuff itself causes a very tightening feeling in your arms, and which is sometimes very uncomfortable. So patient should be aware about this, that okay, every 15 to 30 minutes during daytime, the cuff would be inflated. So he should be relaxed and he should not flex his arm and keep it in a same, what we say, a stable position. So we should tell them, patient, whenever the cuff gets inflated, keep your arm relaxed, keep it still, and once the cuff gets deflated, then start the activity with your arm. So usually this cuff is tied in the non-dominant arm. And patient should be instructed on how to stop an individual measurement if it commences at an inconvenient time. Usually the monitors have a small button on it in which, suppose you are not feeling comfortable that there is inflation, you can just press that button, the inflation will stop. So patient is not in a comfortable position and the BP cuff starts inflating, he can simply press that button and the inflation of the cuff will be stopped. So after this recordings, what does it give? So it gives a BP measurements during daytime, whatever the time period which we have designated, either 6 a.m. to 9 p.m. or 7 a.m. to 10 p.m. Then it gives the nighttime measurements, that is during that time period, what is the mean blood pressure, and then it gives the average 24-hour blood pressure. To say that, okay, this ambulatory BP monitoring report is validated, before that, always be sure that the minimum 70% of readings which have been taken by the machine, they should be valid. It should not be that error should be there, or it should not be a very haphazard or very high recordings should be there, reading are there, which is not explained by patient's usual recordings. So at least 70% of the readings should be valid in these cases. So, but why we want to do ambulatory BP monitoring? Why won't say, okay, we just see the clinic BP recording, and why we want to tie the machine to the patient and send him back for 24 to 48 hours and ask him to come back again? Why we need that? So as I told earlier, there are studies which have shown that this ambulatory BP monitoring predicts better clinical outcomes as compared to your clinic BP recordings. So there were 8 studies which were superior to clinic BP monitoring, and 1 study showed there was no significant difference. So these are the different studies which were started in basically 2004 to 2012. And if you see these studies, they basically evaluated outcomes in patients of in terms of cardiovascular morbidity and mortality. So they did a follow-up for about 6 to 10 years. And they found that whenever the office and ambulatory BP monitoring, the ambulatory BP monitoring had a better outcome in terms of assessing the cardiovascular morbidity. So these were the studies which are ranging from maybe 300 to 10,000 patients, and they evaluated this. I will not go into detail of these studies. And this was all the recent studies in 2007, and they all showed that whenever the cardiovascular mortality, when we see in the ambulatory BP monitoring, was a better predictor to assess the cardiovascular mortality and morbidity as compared to a clinic BP recording. So obviously the patient, if having a better control of blood pressure when as measured by ambulatory BP monitoring, will have a better predictor, better cardiovascular outcome as compared to patients who are just monitored on clinical BP monitoring. So there was this good study which evaluated patients with non-invasive 24-hour BP monitoring, and they showed that ambulatory BP monitoring, they correlate better with the organ damage, and they had a stronger relationship with the cardiovascular mortality and morbidity than the office BP recording. Whereas if you see, there was cardiovascular events were definitely higher in patients with a lesser nocturnal dip. I will tell you what you mean by nocturnal dipping. Ideally, the blood pressure during night time should fall because the patient is at rest, the sympathetic activities are to the minimal. So the patient blood pressure should be lower than the blood pressure of the daytime. So during night, usually the BP fall by 15 to 20% as compared to daytime. But if there is a fall of the BP is less than 10% during night as compared to morning, that means the patient is having an increased sympathetic discharge and there will be your increased cardiovascular events in future in this patient as compared to the patients who had a very good dipping during night. The second important thing by ambulatory BP monitoring, ABPM helps us in, it's avoid over-treatment. It has been, there was a study published in 2007, which showed, the meta-analysis showed that there was 30% of the patients with persistently elevated office BP monitoring, BP pressure, ABP document adequate or excessive control of hypertension. That means the white coat hypertension, which is usually can be seen in these patients, and the drugs are usually increased depending on their office BP recordings. When the ambulatory BP was added to it, there was 30% reductions in these patients despite having with the same treatment. So it avoids over-treatment or escalation of the antihypertensive drugs. The second is your home blood pressure monitoring. So what is home BP? It's now the guidelines also recommend that the patients should go for a home BP monitoring, because if you see, the blood pressure would be measured in a environment which is more friendly to the patient. So patient, the anxiety level, the anxious, the patient becomes very less in these cases. So that when the anxiety level is on the lower side, there will be relaxation, the sympathetic discharge would be less, and that will give the exact reading of your, adequate reading of for your blood pressure. So how to take the home BP monitoring? We all know, we all usually have seen the small devices which go for which are based on oscillometric phenomena and the oscillometric technique, and this measures the blood pressure. But certain tips should be told to the patient while doing the blood pressure monitoring in home. Ask the patient to relax, sit comfortably, keep his arm at a rest state. It should be supported, and the cuff should be of adequate size, and it should be tightly fit. The patient should not have taken any coffee or tea half an hour prior to your BP measurement, and he should have not gone just after exercise should not be done. So at least 2 consecutive measurements should be taken at least 1 minute apart, and with the person seated. BP should be recorded at least twice in a day. That means in the morning time and in the evening time, and it should be recorded for at least 4 days, but ideally 7 days. So total 14 recordings should be done in a patient of home BP monitoring to diagnose whether he is hypertensive or he is not hypertensive. So you will ask the patient to get a flow table of your 14 readings, and depending on that 14 readings, you should we will diagnose whether the patient is hypertensive or not hypertensive, and the treatment, whether it has been started, is he adequately controlled or not. So there are certain advantages with home BP monitoring. What are these advantages? See, home BP monitoring as ambulatory BP monitoring, they predict cardiovascular morbidity and mortality better than the office blood pressure. Second important is patient self-monitoring. We all know, see, like we are all advise these patients, suppose diabetic patients, we advise, okay, you should measure your blood sugar level and all that during at home. So it has been seen when the patient measures its own blood sugar levels, he gets more strict, and he gets more disciplined while maintaining taking his tablets and controlling his diet. Same way, when the patient is advised to go for self-monitoring of blood pressure, it has been shown that the patient becomes more adherent to his medications and the BP control is better. So home BP monitoring also helps in the patient's adherence to the medications. Second, home BP monitoring is more reproducible BP data and more related to your organ damage, particularly LVH. So the patients having a controlled home BP monitoring and a blood pressure is controlled at home, then the target organ damage decreases significantly as compared if they were just monitored on office BP. So this was a study which was published in 2013, and they evaluated, okay, they gave the patient go for a self-monitoring in these cases. So they found that there was a greater decrease in blood pressure at the end of the 6 months when the patient were advised go for a self-monitoring as compared to just on office BP readings. And there was a greater decrease when at the end of 12 months when they were compared with your just office treatment. So that means it's a sustained result, self-monitoring, and because of more patient adherence and better reduction in blood pressure as compared to just office blood pressure. So these were the two modalities which have been advised out of office blood pressure monitoring. So how to use in a clinical scenario? So what is their utility? First and foremost, as I told you, in diagnosing the hypertension is important. So if the patient is having raised reading in office BP monitoring, patient should be advised either go for ambulatory BP or go for a home BP monitoring. And if still these BP recordings are on the higher side, that means the patient is hypertensive and the treatment should be started. Sometimes what happens, the BP readings in the office are elevated, but BP readings at home or ambulatory BP readings are normal, or that means the patient has your white coat hypertension. We all know white coat hypertension is patient's office BP readings would be on the higher side, maybe due to anxiety, maybe due to stress, or seeing a medical professional. So these patients will have a little higher BP when they go for a office BP reading. But when the home BP readings are checked, then these patients have a normal BP readings. So these patients can be easily diagnosed with these two modalities. Second, say initiating the treatment. So once you have diagnosed that, you know that the diagnosis of my hypertension is not proven, it is not a false reading. So the treatment can be started in these cases. And third important is your monitoring antihypertensive. So if these patients doesn't have your BP readings which have been showing good control, then you can easily modify the drug treatment according to his BP recordings. So how to interpret ambulatory BP monitoring? See, we get a data, suppose we take a BP of every 30 minutes. So we have readings of minimum 50 to 60 readings which comes to us with your blood pressure monitoring. So how to read these readings? Should we take a single reading? Okay, one reading of 170, patient is hypertensive and all that, or should we take an average? So whenever a cuff is tied, so initial 1 hour of the period is considered to be a white coat or women period, which we usually don't consider in our analysis. We assume that the patient is still in the clinics and he is still having some anxiety, and a white coat hypertension can be there. Then during the daytime, the BP is recorded, and the night, whatever the measurement which we have taken from 10 p.m. to 6 a.m., that is labeled as a night period. And here the patient is asked to remove the ambulatory BP monitoring. So this is the night period. Suppose I label it from 9 a.m. to 7 p.m. or 8 a.m. This is the night time. This will be your morning time, and this will be your white coat window period, that is initial 1 hour, just putting the cuff, because that will also give you your false reading of the white coat hypertension. So then the average is taken out of the daytime recordings and average of nighttime recordings. Then the average of whole 24 hours period is taken, excluding this 1 hour period. So what all things we can get? We can diagnose a white coat hypertension, as I told you. If the clinic BP is more than 140/90 at least 3 occasions, and his ambulatory BP monitoring is within normal range, then that means the patient is a white coat hypertension, and there is no need for starting an antihypertensive in these cases. But these patients should be on continuous monitoring, because it has been shown the patients who have white coat hypertension, they develop hypertension a little earlier than as compared to those who have a normal blood pressures. And it can be seen up to 10 to 20% of the patients. The second thing, modality diagnosis which we can make is your masked hypertension. So see, masked hypertension is a term in which is basically the patient clinic BP would be normal, but his out of office BP, that is either ambulatory BP or a home BP, would be on the higher side. So that is a masked hypertension, and this masked hypertension can be seen into 20 to 50% of the 40% of the cases. It has been shown because patient has a masked hypertension, his clinic BP would be normal. So we will say, okay, there is no need for starting any antihypertensive in these cases, or no need for increasing or modifying the doses. So these patients have a higher BP on the 24-hourly. So that will cause more risk of cardiovascular morbidity and mortality. And it has been shown that there is your considerably possible high risk with target organ damage. The third important thing which we can see by ambulatory BP but difficult with home BP is your nocturnal dippers. As I already told you, during night time the BP usually falls by 15 to 20%, but in certain cases, especially in CKD and all that, if the BP doesn't fall more than 10% and it is less than 10%, that means the patient is a non-dipper. So if they're non-dipper, studies have shown the patient with non-dipping of blood pressure, they have a increased cardiovascular morbidity and mortality. So certain ratios have been described according to what is the dipping level. So ideally, if the ratio is nighttime to daytime, if it is 0.9 to 1, that is just a mild dipping would be there. But if it is 0.8 to 0.9, that is your dipping is good. But if it is more than 1, that means ratio is that is no dipping, and that is a red flag sign to be evaluated in this patient, and your antihypertensive doses or antihypertensive regime should be modified. So what are the causes for non-dippers? As I told you, the most common causes are the sleep disorders or obstructive sleep apnea in these patients who have either a raised or a non-dipping of the night blood pressures. CKD, diabetic neuropathy, obesity, and high salt intake and autonomic dysfunctions are other to be named. So whenever you find this, these things should be ruled out. So this was study in a CKD patients, and they found that when they did an ambulatory BP monitoring in 217 patients, and when they followed up for a period, they found this non-dipping was associated strong predictor for composite outcome of death and end-stage renal disease. So whenever there is your non-dipping, patients will have an increased risk for developing your morbidity and mortality. The other parameters which can be assessed by ambulatory BP is your morning surge. As we all know, whenever we get up in the morning, there is increased sympathetic discharge, and there is a certain shoot up in the blood pressure during the 1 to 2 hours time period. So if there is a very significant shoot up, that means the patient's sympathetic activity just after getting up is increasing a lot, then that means also signifies that there will be a increased risk of your stroke in the morning. A systolic blood pressure load and a diastolic blood pressure load can also be assessed. What is a load? It's basically, it sees the readings which are above your normal readings of systolic or a diastolic blood pressure. And if these readings are more than 40% of the average readings, that means the patient's having a very high systolic blood pressure, and these have to be antihypertensive should be escalated. And the fourth thing which we can assess is ambulatory arterial stiffness index, which is the ratio of diastolic blood pressure with the systolic blood pressure, average systolic blood pressure towards whole day, and then it depends on the slope is formed, and we see the stiffness in the arterial stiffness index, whether the diastolic blood pressure is getting below the parameters or not. So these things are there, but these are basically for research purposes, not for your in the day-to-day daily practice. We don't use them. So regarding this, what do guidelines recommend? Should we use ambulatory BP or home BP in all the cases? So now ESC and ACC both have given a class 1 indication that the out-of-office BP monitoring is specifically recommended for a number of clinical conditions, especially for a white coat hypertension and a masked hypertension, in quantifying the effect of the treatment and maybe the possible side effects. Sometimes the patient complains of the postural hypotension and all that. Then these ambulatory BP monitoring comes to rescue, and it's a class 1 indication that these should be done in these cases. So what all we can diagnose whenever we go for out of office BP? So these are the 4 clinical scenarios which can be diagnosed by the out of office BP. So if out of office or clinic home BP is normal, normotensive and the home BP is also office BP is also normotensive, then the patient is your normotensive. It has no need for any starting any treatment, or the whatever treatment he is, there is no need to change the treatment. If his office blood pressure is on the higher side, that means he's hypertensive, but his home BP is also on the higher side. That means patient is a true hypertensive and is a sustained hypertension is there. So the treatment should be either started or escalated depending on his clinical scenario. But if his office BP is normal, but his home BP or ambulatory BP is on the higher side, that means the patient is a masked hypertensive, and these patients have been shown that if they don't get treatment because the clinic BP are normal, they have an increased cardiovascular mortality and morbidity in long run. And if we find our office BP on the higher side and the home BP or ambulatory BP on the normal side, so we know these patients are usually white coat hypertensive, and these patients, treatment in these cases should be not needed, but they have to be regularly followed up because have been shown to have development of hypertension at an early stage. So if we want to use in a patient, which one is superior? Should we go for an ambulatory BP or should we say just home BP monitoring? So is there any preference over other modality depending on the clinical scenario? So if we see the advantage and disadvantages, the disadvantage of ambulatory BP monitoring, if you see, is the availability. So we all know the availability of ambulatory BP monitor is still not available in each and every clinics and each and every hospital. So that becomes a big drawback. Second is the cost issue, because it is during every investigation, it will be charged. So the cost issue becomes a major problem. And third is your patient discomfort. You all know the cuff inflation in the arm itself is very uncomfortable. So if a patient the cuff has to be inflated every 30 minutes during daytime and every 1 hourly or 30 minutes, 60, 45 minutes during night time, that would be very uncomfortable to the patient. So patient usually try to avoid going for this type of a modality. But what are the advantages is that first and foremost, you get a more smooth reading or more continuous readings of the blood pressure in these cases. So you can get a nighttime reading. You can find out whether they have non-dippers or not. You can see whether they have your morning surge or not, how is the average BP whole day it's going on. So that is the advantage of with ambulatory BP monitoring. But if we see the home BP, so home BP monitoring also has certain advantages. Advantages that first is your availability. It's just not a very expensive machine of 1,500 to 2,000 rupees. You can easily get from your any pharmacy. The BP readings can be done according to your convenience. You can take your BP readings whenever you are comfortable. Cost issue is just a single investment, and this can be used maybe for a few years, and you don't have to buy it again and again or have to pay again and again for the BP readings. But there are some disadvantages. So disadvantages are first and foremost that it's not a continuous monitoring. So you're not very sure about the nighttime blood pressures or the morning surge. So non-dippers cannot be diagnosed with this home BP monitoring. Second, selection bias and chances of errors. How the patient is keeping his arm, how he is trying to put the cuff, whether he has taken any correct prescriptions or not, that becomes a very big issue in these patients with home BP monitoring. But both modalities can be used depending on the clinical scenario, what are the clinical indications. So there was one study which compared office and home ambulatory BP monitoring as a predictor for cardiovascular mortality. And when they compared this office, home and 24 hours monitoring, they found that 24 hours home BP monitoring has a better outcome or better model to predict the hazard ratios in terms of cardiovascular morbidity and mortality as compared to your office and home BP monitoring. So what does the guidelines recommend, or what does the protocol, or when you should be advising these type of out of office BP monitoring? So if you see, patient comes to you and you take his BP monitor BP, If his blood pressure in the office is less than 120 by 80 or 130 by 80, and after 3 months of lifestyle modification, but you suspect there is masked hypertension, that means if the patient has some left ventricular hypertrophy or there is some target organ damage, and there is very high clinical suspicion that the patient is hypertensive, then these patients should go for your ambulatory BP monitoring. During ambulatory BP monitoring, if his daytime BP is coming more than 130 by 80, that means he's hypertensive and he's a masked hypertensive. So you have to start with your antihypertensive and continue lifestyle modification. But if his BP is not on the higher side, that means he's having normal blood pressure, then he's having to go for a just lifestyle modification to be advised in these patients. And if you find that there is target organ damage is there or the patient having LVH, you can advise annual BP monitoring in these cases to rule out there is any masked hypertension or progression in the blood pressure. If the office BP first reading is more than 130 by 80, but it is less than 160 by 100, that means not a very severe or high raised blood pressure, then these patients can be due to your white coat hypertension. So when do you suspect white coat hypertension? Is that young patient, very anxious patient, and he has no family history, there is no target organ damage, and his BP readings during office are always coming 150, 90 or something like that. So you should suspect a white coat hypertension in this case. Go for either an ambulatory BP or a home BP monitoring. If you find his blood pressure is less than 130 by 80, that means he's a white coat hypertensive. You just tell him go for a lifestyle modification, but you have to closely follow him up because white coat hypertension is still not a very benign disease. But if his blood pressure during daytime and all that still elevated when compared to your office blood pressure, that means he's a sustained hypertensive and antihypertensive should be started in this patients. So coming back to the clinical scenarios which I discussed before starting my talk. So if you see this patient in your OPD now, she is a 40-year-old female, she is non-diabetic, she has comes to your OPD, she has 2 readings of 150 by 80, she is little anxious, her heart rate is on the higher side of 110, there is no evidence of target organ damage. So what to do next? So we cannot diagnose this just on 2 readings of 150 by 80 with no other target organ damage or family history. And so we should at least identify or diagnose whether she is really hypertensive or is just a white coat hypertension is there. So you will say, okay, go home, do your home BP monitoring, take at least 2 readings per day for minimum for 4 to 7 days and come back to me. You will see all her home BP readings and take out the average. If on average also, if the BP is on the higher side, then she is a sustained hypertensive. So you have to start the treatment. But if it is normal or the blood pressure is lower, that means she is just a white coat hypertension is there and there is no need for any medication and she to be advised go for an annual checkup. Coming to the scenario 2, if you see this, she 55-year-old male, he is having a renal dysfunction, he is already on 2 drugs antihypertensive therapy and his BP readings are always coming less than 140, 90 and 130 by 80. But still there is progressive renal dysfunction, there is left ventricular hypertrophy. So what to do next? So it may be possible that the patient is a non-dipper or his BP is not getting controlled the whole day. So these patients should go for an ambulatory BP monitoring, go see for the nocturnal dipping pattern. What will you do in the case scenario 3? He is a 30-year-old male. His BP is always coming 130 by 80 in your clinics. But when you evaluate there is some mild renal dysfunction and he's having concentrated left ventricular hypertrophy. So that means you are having a target organ damage with a normal clinical blood pressure. So it may be possible he might be a masked hypertensive, which can be seen in 10 to 30% of the cases. So we should go for either ambulatory BP or a home BP monitoring in this patient and rule out that there is no masked hypertension in this case. A case scenario 4 was a 65-year-old lady. She is in a in atrial fibrillation. She is already on 3-drug antihypertensive therapy and still her blood pressure is on the higher side, that is 180/100. Should we go for an ambulatory or a home BP? Two things, these both methods are depend on the oscillometric method. So whenever there is atrial fibrillation, this modality or this technique becomes problematic to diagnose blood pressure or to take BP in these cases. So there will be no role of ambulatory BP monitoring in this case. Start with antihypertensive or modify the antihypertensive, escalate it, and follow up her in the OPDs. So in concluding, so conditions in which I might use your out of office BP monitoring or ambulatory or home BP monitoring are a patient, I have a suspicion for a white coat hypertension, or patient is having an episodic hypertension. Patients sometimes say whenever there is a stress or anxiety, my blood pressure shoots up. In that cases, your ambulatory BP monitoring comes to rescue. I'm seeing a patient who is normotensive during my clinics, but he is having target organ damage in the form of either LVH or renal dysfunction. I would like to do a ambulatory BP monitoring in this patient to see whether there is your past hypertension or this case. Second would be hypertension resistant to medications. So if it is resistant to medication, it may be possible that patient is having white coat hypertension or your dosing of your medications to be adjusted. Patient is having hypotensive symptoms on medication. The postural drop is there or there is sympathetic overactivity, then again these patients should undergo an ambulatory BP so as to evaluate or measure the blood pressure for the whole 24 hours. We are suspecting autonomic dysfunction or an external nocturnal hypertension, or there is a large variation in the self-measured blood pressure, like some day he say my BP is 190, and some days he says my BP is 130. So to be sure, it's better to go for a 24 to 48 hours BP monitoring to assess the various changes. And fourth would be suspected preeclampsia. What are the conditions in which I would not like to use ambulatory BP or home BP? First and foremost, when the patient is severely hypertensive, so there is no point in diagnosing a white coat hypertension in this case, because 180/100 you have to start an antihypertensive drug. Patient is atrial fibrillation, which as told, AF is, I told you earlier, this method is oscillometric method. So atrial fibrillation will cause your false reading or we can measure the blood pressure improperly. And third would be your patient choice. Would say, okay, I don't want to go for, I think I'm hypertensive and just to start me with the treatment, I have family history, or maybe possible your patient doesn't feel comfortable in that, then I would not go for this ambulatory BP monitoring. Can we use this ambulatory BP monitoring as a screening tool? Now that's a very big question. Why don't we do a population-based study and we say, okay, go for ambulatory BP monitoring? That would be difficult. Practical method still, it is a clinic BP monitoring is to diagnose hypertension as a screening tool. But if the clinic BP monitoring is showing blood pressure of more than 140/90, then it is better to offer a ambulatory BP monitor in these cases to either confirm or refute the diagnosis of hypertension. So in concluding my talk, I would like to just say that out of office BP monitoring or in the form of ambulatory BP or a home BP monitoring is an important tool. First, in identifying hidden hypertensive. Second, in avoiding overtreatment. And third is important is your monitoring the antihypertensive therapy. So by this modality, we can diagnose, we can treat, we can underdiagnose, we can undertreat these patients of hypertension. And as already told, this modality is better predictor than just going for a office BP or a clinic BP in our settings. Thank you.